Tonight, George is going to have an opening statement. He'll present some of the different things he has to talk about. We'll introduce the board. And thank you all for your time this evening, and thank you to the board for coming. George, it's all yours.
Thank you, Bernie. Thank you, Bernie. We really appreciate the hosting here at the town hall and the opportunity to talk to you about vaccines in our community. My name is George Fjeld, and my fellow panelists and I will try to educate you about the basic mechanisms of vaccines, what they've done for the human race and for our population right here, and why they're important going forward. We'll do this by presenting information about vaccines, how and why they work, and leave plenty of time for your questions. First, let me introduce, just so you know who people are, my fellow panelists, David Schneider, Benjamin Bearnot, and Abby Wikoff. You'll get to hear from each of them in turn, and I'll let them tell you about themselves at that point. Myself, I moved to Brandon and finished high school here, graduating from Otter Valley in 1973. I attended UVM for 8 years, did a residency in Philadelphia, and returned home to Brandon. I practiced here from 1984 until 2020 when I retired. During that time, I saw how remarkable vaccines were in reducing disease amongst my pediatric patients especially. In my personal and professional opinion, I believe vaccines have been a triumph of modern medicine. They have eliminated smallpox from the world. They have reduced the frequency and severity of a great number of childhood diseases, including mumps, measles, German measles, whooping cough, diphtheria, tetanus, meningitis, pneumonia, and sepsis. Now, there's some relatively interesting things to talk about. One is, what's immunity and what's a vaccination? Immunity is when your immune system can prevent a bacterium or virus from invading you, so you have immunity. And there's two basic ways to get immunity. One is called natural immunity. Natural immunity is when you get the disease, and if it doesn't maim or kill you, you will, for the most part, be immunized against that. You can also get a vaccine, and the vaccines, through rigorous scientific research, are very safe, cause little, almost, well, certainly negligible harm, and provide tremendous good. Let me tell you how I saw vaccinations change the spectrum of diseases afflicting my patients. Speaking specifically about Brandon, we had a resurgence of pertussis back in the 1990s. In 1 year, while I was practicing, we had the most cases of pertussis in Vermont, here in Brandon, Vermont, mainly because I was testing it. Now, pertussis is whooping cough, and whooping cough is terrible because you cough, 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 cough. So that's why they call it whooping cough, because you cough and then you whoop to try and get some air in. I saw many patients with the disease. It's treatable if you treat it before you start coughing. So that's a really interesting thing, right? And so what I did was, when we saw a patient, we'd isolate them. We'd treat all their close contacts with antibiotics to prevent them from getting the infection that would produce the cough and that would not go away for weeks. So, subsequent to this outbreak, which occurred not just in Brandon and not just in Vermont, but across the country, we changed our immunization practices across the country. We started giving adults, instead of just a tetanus booster, when we gave them tetanus, we gave them tetanus with diphtheria and pertussis vaccine. So we immunized them against 3 terrible diseases with 1 immunization, instead of just leaving them to natural immunity. So this adult immunization reduces the likelihood that an infant will contract whooping cough from a parent, relative, friend, or grandparent, and that is what we call herd immunity. You can't get the disease if you're not exposed to it. polio was eliminated pretty much before I started practicing. Most everybody had a polio vaccine. There are people in the audience who were born pre-vaccination and had the disease and have it affected. So what happened was with polio, we changed from a live vaccine to an attenuated vaccine because the live vaccine had a very, very rare chance of causing actual polio, like 1 in a million. But because we did such a good job of immunizing people in this country, the risk was greater to get polio from the vaccine than it was to get it from nature, because nobody in the country had polio, and the only cases we were seeing of polio in the country in the 90s were coming from abroad. People were coming in bringing polio, and those people got isolated, and it was taken care of relatively quickly. So we changed our immunization practices based on evidence. We used a less effective vaccine because we had a disease that was not as prevalent, and we did not produce a strong immunity, but we had no chance of causing a polio infection. During the early years of my practice and while I was training, pediatric meningitis was altogether too common infection. Baby came in with a fever. You know, we looked for things like swollen fontanelle and stiff neck and tried to sort out whether it's possible they had meningitis. Meningitis is an infection of the structures that surround the brain and can result in deafness, death, and brain damage. So the influenza type B vaccine, or HIV vaccine, which was introduced in 1984, became widely prevalent by 1990 and reduced the incidence of meningitis in infants tremendously. It also reduced the risk of pneumonia, otitis media, and bloodborne infection. In 1984, meningitis accounted for 5 deaths among 100,000 children under age 5 every year. In 2021, the most recent time we have data for, meningitis accounted for 1 death in 200,000 children under age 5 in a year. This is a 90% reduction and a very, very dramatic difference. So, before we move on to presentations from the rest of the panelists, we'd like to do a short skit for you. We hope that it'll help you understand how immunizations work. So bear with us as we go through this.
Very serious.
We're very serious. Yeah. We're very serious. But in this skit, we're going to try to show you how a vaccine works. David is going to be the host, or the person who we're trying to prevent getting an infection. Ben is going to play his immune system. Abby's going to be the invader, the bacterium or virus, who's going to try to attack David, our host. And I get to be the vaccine. And I'm going to help David and Ben know what Abby looks like so they can prevent an infection. All right. As the vaccine, my job is to take an image or a part of it and show it to David's immune system. You look very ferocious. All right. So let's take a look what we got here. Look at this picture. I have too many things to hold. I have too many things to hold. All right. David and Ben, take a look at this picture.
All right, so we got some recognizable mittens. I would know those if I saw them again. I see this polka dotted shirt, that smile with the eyes closed and the glasses, all black otherwise. I think I got it. If she comes around here, she won't get close to us.
All right, thank you. All right. So, that's my job as a vaccine. I was by the virus, took a picture. I could have also taken one of her gloves and brought it over to Ben and showed it to him. And now, Abby, the virus, is going to attack the host.
You have the gloves, you have the polka dotted shirt, you're wearing all black. Stay away from my host.
All right. It worked like a charm. So, thank you very much for indulging us. I hope that gives you some small idea about how immunizations actually work. Obviously, it's not pictures, but it's much more, we take literally parts of or proteins from the bacterial virus and mount it and show it to the immune system. And now I'd like to turn things over to Dr. David Schneider, who's a retired pediatrician from the Rutland area and former.
Thank you. I come in across okay?
Getting good and close to you. There you go.
There we go. How's that? Good? Okay. Great. Greetings. Hello. David Schneider. I came to Rutland in 1993 and never left. Never. Don't think I ever wanted to. Maybe once or twice, but not for long. I was just very proud to be a pediatrician practicing in the state, in our community. I would say I don't like to call myself a retired pediatrician. I'm a pediatrician who stepped away from clinical practice. I live and will die as a pediatrician. Right now, my focus is more on advocacy for the state of Vermont, trying to help improve healthcare. And at the same time, having a lot more free time, which is really nice. So that's pretty much me in terms of where I've come from and what I'm doing these days. I was wanted to gear things that I have to say pretty much based on the people who I'm talking to. Looking around, I'm just wondering how many people, let's say under 35 or so, are here right now? Okay, good. All right. Well, it does change things for how we look at how the conversations can go. So the vast majority of people here are over 35. There are a few who are under 35. Of those who are 35 or so or younger, are there parents right now in the room? There might be some online. Of young children? Of
15 in May.
Okay, good. Okay, so teenagers. You said 15? Okay, yes. And how old are your children? You're willing to share?
1.5 and 3.5.
Okay, and how about grandparents in the room right now who are actively involved in the care of their grandchildren with approval of the parents? Okay, beyond just giving who are actively involved. So quite a number who are actively involved in the decision making about the health care of their grandchildren. Any? Okay, good. No, but from time to time, perhaps your child will seek your advice. 50-50 chance they ignore it, right? Or tell you how you're wrong. Right. Good. So the vast majority of people here grew up at a time when there were many immunizations that we do not have. Right. There were many illnesses. There were not many immunizations that we do have right now. So if I were to ask who has seen chickenpox, probably a lot of people would raise their hands. And everybody who has seen it has probably had it, correct? Okay. Who here has not ever seen chickenpox? Under 35, right? Okay.
I have it, and shingles.
And shingles,
Yeah.
yes, right. And shingles. Who said?
Me.
Under
At my
35.
college graduation, I got them back to back.
Oh.
Nice graduation present.
So the chickenpox vaccine, for example, probably became, it was introduced probably in the very early 90s, late 80s or so, became part of the routine immunization schedule, mid-90s, say, probably about 95 or so, maybe 94 or so. But still, there's like with any new vaccine, there might be some hesitancy of getting it, first of all, and second of all, finding its place in the schedule and deciding whether you need one vaccine or two, as we're learning more about the vaccines that are out there. So prior to the routine use of the vaccine, there was not a single year that went by that I was not hospitalizing rather sick children with chickenpox. Now, most of us who have had it here, we knew I was probably 6, and I still remember the itch. I remember, everybody's nodding, right? We remember the itch, we remember the feeling lousy for about a week or so, plus or minus a few days. But you miss a week of school, maybe that's good, depends what you're doing. But most people, born after about 1995 have just simply not seen chickenpox, or very little. Every once in a while, there'd be like a chickenpox outbreak scare, and it almost invariably is not. Somebody happened to see somebody who had a few bug bites or so, and they forget about the sore throat, the fever, the vomiting, the diarrhea, and just feeling lousy. But as you get older, if you remember, if you were a teenager getting chickenpox, it was quite a bit worse, and some of these older kids. And they were the ones I would be admitting pretty much every year, somebody somewhere with significant, mostly pneumonia, an occasional viral meningitis, sometimes even secondary skin infections, which, if you remember the flesh-eating bacteria we used to have, secondary chickenpox. So that's just one example of vaccines of illnesses that were considered everybody got, most people got through them. There are still to this day families who have chickenpox parties. Unfortunately, there's an occasional devastation out of that. When in a vaccine-preventable illness like chickenpox, there should be zero morbidity, zero mortality. Unfortunately, every year chickenpox did kill and get some people really rather sick. And also with the chickenpox parties, where people would intentionally cause a quote natural immunity and get their children sick. They would, some of them would get too sick, if you will. So, and later into my practice, all the new pediatricians who have come in, they've never seen chickenpox, and it was almost jaw-dropping to me that such a thing, that we would be in that state, that this illness has just been completely, potentially eradicated. One vaccine is about 90% effective at eradicating, at causing full immunity. 2 vaccines, the second vaccine, brings it, in the high 90% that we're just not going to see chickenpox. So also, over the last years, if I ask people right now, George mentioned polio, and some of the people from the pre-60s or so, and there were a few of us in the room here, have certainly known people with polio. And as George mentioned, there may be people in this room who have survived polio. Not everybody did survive polio. And of course, the devastation associated with that. Now, I grew up, polio was not something I ever saw in practice, but I do remember, I was young enough, born in the very early 60s, although there were not big polio outbreaks at the time, there were all these, young adults who were either in a wheelchair or with any number of paralytic sequelae associated from getting actually polio. And as George talked about, the evolution of the polio vaccine, everybody, right, first there was the Salk vaccine, then came the Sabin vaccine. Again, most of us in the audience will remember those names. The Salk was the shot, worked pretty well. And the Sabin vaccine a few years later was much more effective. It's something, first of all, called herd immunity. It was an attenuated, meaning a crippled live virus that would be given, kids would wait in line for the little sugar cube perhaps, and they would swallow it, and it would actually be transmitted because it went in the mouth and came out the other end, could actually cause a true herd immunity in the community, where just because that virus was now in the community and shed, certainly in daycares where diaper changes can certainly lead to the transmission of some bad things, and in this case actually some good things, where even people who didn't get the oral vaccine, they could have gotten some level of vaccination from the polio vaccine that way. But there was some small risk. It was worth it at the time because of the high amount of polio. The oral polio vaccine is still given in numerous countries right now, where there's still outbreaks. But in the United States, as George mentioned, now because it was no longer worth the risk, we give the inactivated polio shot. And if we were to go down other illnesses, with this age, who ever heard of rotavirus? Rotavirus. Who ever heard of diarrhea? Who ever heard of really devastating diarrhea in infants that will cause them to dehydrate and possibly end up in the hospital, and probably the most common cause of diarrhea in infants? Well, that's rotavirus. That's rotavirus. What it used to be the most common cause of infant hospitalization for dehydration not too long ago. And I bring that up for the rotavirus vaccine. I wanted to mention it because it's an example of side effects and problems associated with vaccines. There's a mythology around that many vaccine side effect studies are being ignored. And when the reality is they're not actually being ignored, they did not stand the test of actual peer review, of actual science. Okay? However, there have been times when vaccines did have side effects that did withstand peer review and scientific review. And the first rotavirus vaccine was one of them. It was very effective, but it did have a side effect of intestinal obstruction in babies. It was very, very, very rare because intestinal obstruction in babies is so rare. But it looked like it might be a little more associated with the rotavirus vaccine. And this was actually not too long ago. This was probably in the mid-90s, 1995 plus or minus, that the first RotaShield, it was called, vaccine came out. And again, it was incredibly effective at dramatically and quickly reducing the number of hospitalizations, a good thing. But there was a little distant risk that this may have happened. So that it had a side effect of intestinal obstruction, which could be actually devastating to a baby. So the vaccine was pulled, and it was pulled for quite a while, and then reformulated, it was remade. But the point is, there is a response when we see in vaccine science, when there is a problem, the vaccine is pulled. When there's beyond the typical common side effects of fever, soreness, signs of your immune system working and responding to the vaccine. One other example would have been the swine flu vaccine in the 70s. There was an elevation of something called Guillain-Barré syndrome. It's a transient paralysis that happened and could be associated with many, many, many viruses. They didn't know it was from the virus or the vaccine. Didn't take a chance to pull the vaccine. And it probably was from that formulation of vaccine that year, that one time. So these things are always, always being monitored. So when people, right now we hear quite a bit out there that many vaccines and the studies that are clearly showing all sorts of problems, but they're being ignored, we hear. They are not being ignored. They're being rejected by the scientific method. Science is simple. If you can't prove it, you made it up. Okay? And so a lot of science starts with making things up. I have a postulate, I have a hypothesis. Now I have to prove it. And I can't just prove it once, it has to be replicated. It has to be replicated every single time. As soon as you say, wait, I can't do this again, then something fishy is going on here. And that's what has happened with much of the, quote, rejected immunization data. And I'm going to leave it at that because I've been talking a while. But that's kind of the perspective I'm coming from, is to talk about the effectiveness of vaccines, the history of illness, and if I can answer some pediatric questions, I hope to do that.
Thank you, David. Ben, you're up next.
Wonderful, thank you. It's an honor to be here. My name is Ben Bearnot. I am a primary care and addiction medicine doctor. I live here in Brandon with my wife and 2 kids, and I've practiced in Middlebury since 2023 in Middlebury Family Health. I trained in internal medicine, addiction medicine, and did training in public health at Mass General Hospital and Harvard Medical School before moving closer to my wife's family going on 3 years ago. My main disclosure and conflict of interest is that I'm George Fjeld's father or son-in-law, and that he is one of the top 2 best of fars in all of Brandon, and he'll have to take up that argument with his brother Carl. Today, I'm going to outline the remarkable public health impact of vaccination programs, focusing on their contributions to life expectancy, talk briefly about their economic benefits, and some major quality of life benefits that have been supported by really robust research that, if you have specific questions about, I'm happy to review with you. But before I get started on the data, I want to tell you a story about a group of my patients. It's about 10 to 12 patients or so who are about my age, in their late 30s and early 40s. And I usually meet them after they've received treatment for a head and neck cancer, so cancer of the mouth, throat, tonsils, nasopharynx. The radiation, surgery, and chemotherapy that they get often leave them with chronic pain and disability, curtailing their quality of life. Many, if not most, of these cancers are caused by HPV, or the human papillomavirus, most commonly known as the virus that causes cervical cancer, but also causes head and neck cancers. And there's been a vaccine available since 2006. And I had these patients in mind as I was writing this talk, and I will come back to them at the end. I think most importantly, I wanted you all here today to hear that vaccination represents the greatest health intervention for mortality reduction in the past 50 years. Since the 1970s, vaccinations have saved 150 million lives globally, mostly 95% of which are among children 5 or younger, and we estimate 9 billion years of life saved. Right, and a 50% reduction in child mortality since 1970. In the United States, since the 1990s, we expect that vaccination will have saved 1.1 million lives among children, and financially, we estimate over $550 billion in healthcare savings. And when you look at societal costs of those children growing up to contribute to the economy and their families, closing in on $3 trillion of saved societal costs. So not only a public health benefit, but a clear financial benefit as well, including the fact that estimates are that for every dollar spent on a vaccination program, $44 come back to the community in terms of saved healthcare spending and societal benefit. One of the most cost-effective public health benefits in the history of the world. All right. I think that talking about children in vaccinations is really important, but as an adult medicine doctor, I also wanted to pivot to talk about the longer-term individual and public health benefits of vaccination. The 2 areas I'm going to talk about are dementia and cancer prevention. There is a strong and growing evidence base that vaccinations prevent against dementia. Right now, the main vaccinations that have been studied include the herpes zoster or shingles virus, which using natural experiments or causal inference have been shown to decrease new dementia diagnoses by over 20% in adults who receive the shingles vaccine starting at age 50. Additionally, the influenza and pneumococcal vaccines have also been demonstrated to reduce dementia. And with the flu vaccines, the greater the number of vaccinations, the greater the reduction. Individuals with high risk, those who received 4 or more flu vaccinations, had over a 50% reduction in incident dementia diagnosis. All right. So I think it's pretty profound that how even receiving vaccinations in adulthood can change the course of your health. And lastly, I wanted to talk about cancer prevention. In Taiwan, where chronic hepatitis B is pretty common and maternal to fetal transmission is common, when they introduced universal hepatitis B vaccine, cirrhosis and liver cancer in children almost entirely disappeared. And it's a relevant one to talk about today, as hepatitis B vaccine is one of the vaccines that is being delivered a little bit later in life as a result of changes in the vaccine schedule, which we may get to in a little bit. And finally, turning back towards HPV. HPV vaccination is associated with a 2/3 reduction in overall cancer risk, and particularly when given to children before they turn 15. It's sometimes cutting out on me. And I think that I just wanted to end by saying that vaccine programs deliver extraordinary public health value through reductions in morbidity and mortality and these economic returns I've talked about, but maintaining high vaccination coverage across the lifespan is essential to expand and sustain these gains. In personally reflecting on what I have presented here today and thinking about those dozen or so patients of mine with head and neck cancers, I've come to a personal conclusion that I'd like to share tonight. The age for receiving the HPV vaccination has been consistently revised upwards and is now up to 45 years old in some populations. And I plan to discuss HPV vaccination with my local primary care nurse practitioner in Brandon when I see her next month to have my annual physical. I think it's worth demonstrating that while I don't consider myself at being high risk for HPV or HPV-associated cancer, I don't know what the future holds. And I want to make sure that I'm healthy and around to be there for my family as long as possible. And I wanted to share that with you today. I look forward to answering your questions during the town hall portion, and thank you so much for your time and attention.
Abby, we'd love to hear from you.
Yeah, okay. Hello, is this good? Can you hear me? No?
Pull it close to you.
Okay.
Pull the mic right to you.
Sometimes I'm pretty loud without one. I don't think it's... Is it working? Oh, there we go. Okay. Hi, my name's Abby. I think I'm shutting off the ears.
Yeah. Once I got close enough,
Is it just out?
I don't know. There we
get
go.
uncomfortably close.
Yeah, you have to get really uncomfortably close. Okay, that's good. Well, I'll just be really close to it. Yeah, let me try that one.
Work for David.
Perfect, okay. Okay, so I work at the local community, Brandon Community Health Center right in town. I'm a family nurse practitioner, and a lot of you probably know me. I feel very grateful for living and working in the community I live in, working for. Anyway, so I think that I'm going to kind of start talking about the difference I've seen. I've been out of school. I went to Yale University where I got my master's, and I've been out for now 10 years. I've seen a really big shift in the last 5 years since the pandemic. When I first started vaccines were something I wasn't spending the entire appointment discussing with my patients. Now it feels like it's taking up a huge amount of our appointment, which is fine. It's a big shift compared to how it was before. I've always wanted to work in rural medicine, and I'm really happy I'm working for a federally qualified health center. And I get to see, I treat across the entire lifespan, so from infancy to older age. So I get to see a lot of these vaccines and how it's changing. One thing I thought that was interesting, talking about natural immunity, I saw something when I was preparing for this, calling it survivor immunity instead, saying, you know, since we've been, every bacteria or virus, any disease, is really trying to cause harm to the body. And if it doesn't, you survive, and that's great, but it's not that natural immunity is healthier. And vaccines seem to be like a victim of their own success. So it's been kind of difficult and complicated going through some of my appointments. Anyway, so one example I wanted to give was being a parent. I have 2 young boys, and they are they are 4 and 6 now, but when they were 2 and 4, we woke up in the middle of the night and we heard a whole bunch of noise in their room, and there was a bat in their room. So, of course, we were all frantic trying to get the bat out of the room. We got the window open, we got the bat out. Unfortunately, we didn't catch it, because that's what you should do to test it for rabies. And we were just relieved. We were going back to bed, and I was laying in bed, and I went, oh shoot, what if the bat bit them? And my husband said, no way, the bat didn't bite them. And there's no way, if it did, the bat has rabies. But with my provider brain on, I thought, well, rabies is 100% fatal if you have any symptoms. And we're not vaccinated for rabies. But luckily, it has a long incubation period, so you can receive treatment with immunoglobulin and vaccines. So in the morning, I talked to my husband about it, and I said, I think we might have to go get them vaccinated. And it's not fun to bring a 2 and a 4-year-old. You have to go to the ER. It's not a fun process. And he said, well, what are the chances? But even if it was a 0.001% chance that they could get rabies from this bat, I couldn't take that chance. You know, it's a fatal outcome. So when I explained that to him, I saw his mindset shift, and we went to the ER, and they did great, and the ER was wonderful, and I was so lucky, and I felt so privileged to have access to that. And I share this story a lot with my patients, because I think it highlights what it's like to be a parent and the fear. And I could see my husband saying, well, are you sure? And I've heard that they're really bad vaccines, and that you have this and this and these side effects. So anyway, I like to share that with my patients, and I've seen some of them shift their mindsets when we're trying to discuss going forward with some vaccinations. And yeah, so hindsight's always 20/20 when you look to anything in medicine. So as your provider, your clinician, I'm not working in public health. I really appreciated hearing everything, especially with the numbers and the data and the cost savings. But as a clinician, seeing the shift that I've seen in the last 10 years, I'm really happy that there are people that are requesting talks like this and getting more information and being part of a community that wants to learn more about this. And I was also wondering if, when we start talking, if people need resources to kind of get more information, because I think that's a hard piece my patients share. They're getting a lot of information on social media and doing their own research, which is really interesting to hear. It's almost like we have a team that was doing so well that they felt like they could pull the goalie, and that's kind of how it feels right now in medicine. Yeah, I don't know if that makes sense. But I don't know if I have much to add after you guys.
Well, thanks, Abby.
Yeah.
We're going to invite you up, and let's see if we can see if there's some questions that people have. We'd love to hear what you're thinking about, what And we're here for any of the vaccine or immunization questions that you'd like to ask.
Thank you, George. As I said, they prefer to be addressed by their first names. Keep it warm and fuzzy. So feel free to do that. Keep your questions and statements short and to the point and germane to the issues at hand. Everyone will be allowed one follow-up to their questions to obtain necessary clarity. You will not be allowed to speak again to the same question for a second time until everyone else has had a chance to speak. That keeps us from having just a debate between two people or two or three people. The forum will be on PEG TV at some point in time. Greg is recording it here. And we'll also probably have a link for a YouTube space for it. And that'll be in, I'm sure, social media, Front Porch Forum, Facebook. I'll put it on the chamber website. So this information will be there for future review if you want to, or tell someone about it if you think it's worth for them to see it. Okay, who would like to have the first question of the evening?
Hi, I'm Barbara. I don't need to stand. Do I need to stand?
Well, you don't need to stand because, that's fine, because we're on Zoom, they can't stand.
I'm Barbara White. I'm not sure to which medical person I should direct this, but many years ago I got a flu vaccine and darn it, ended up with the flu. So I decided I would not get that vaccine again. However, with grandchildren coming along and my children being aware that we could bring, illness into the house, they wanted us to get different vaccines. So this year, of course, and subsequent years, we've gotten the COVID flu combination vaccine. My question is, apparently there's a different flu strain out this year that this year's flu vaccine didn't quite cover. Who does the testing? How do they ever know what flu strain might be coming to us humans? Whoever would like to answer that.
Yeah, that's a fabulous question. I mean, influenza is a huge public health problem and an individual problem for anybody who gets it. This question about, I got the vaccine and I got the flu. So when we study that and study it hard and look at all the data, there's no difference between just a normal day and getting the flu vaccine in terms of your likelihood of getting the flu. It doesn't change if you get the flu vaccine. So you got the flu when you got the flu vaccine because you were going to get the flu anyway, unfortunately. But people assign things temporal, meaning if two things happen at the same time, they must be connected. And that's one thing that we look at in medicine very, very, very carefully. Because two things happen at the same time, don't mean they're connected. If a red car drives by my house and the dog barks, my dog must bark at red cars. My dog barked because he wanted to go out. Nothing to do with the red car. So when I looked into it a little further. So it's that kind of process that we look at it, and because things happen once doesn't mean they're causative. So the second part of that question about what about influenza? Why is it so difficult? Why do they miss when they develop the vaccine? Influenza is the great masquerader. Influenza changes its spots every single year. When we had Abby up here as the virus, and we looked at her and we could see exactly what she looked like, influenza in any one year, there's usually about somewhere between 8 and 10 different variants. They look a little bit different. Their gloves might be different. Their hat might be different. Their coat might be different. Their boots might be different. And that, because the immune system looks at everything, if it doesn't look the same, it doesn't attack it. So when we started with influenza vaccine back in the 60s and 70s, influenza was the new strains bred in China, were transported to South America, and then came to North America and Europe. That was the way it came. So we would look for next year's vaccine at what was going on last year in China, and we would be able to predict, because it would be year 1 China, year 2 in South America, year 3 in North America and Europe. And now, with global travel and everything, it's spread all over the world, and it spreads in not predictable fashion. So the people who do this make their best guess, and they include usually 4 different strains of influenza in the vaccine. And they're pretty good. Most of the time they get it. This year, there's a really virulent strain that they didn't get, and it's terrible. But it doesn't mean you shouldn't get the flu vaccine, because there's other strains going around that it is preventing. So, is that, Barbara, does that answer your question?
Yes, I didn't understand that China, I didn't understand that. I didn't know that.
I would also just add too that even if it did miss the strain, it's still, the whole point of it is to reduce the severity. So to keep you out of the hospital, you still might get really sick and achy and have a fever, but just like with COVID, I think a missed message with the pandemic, which is easy now, like hindsight's 2020, is that the COVID vaccine and the flu vaccine may not prevent you from getting those diseases, but it will it's to keep the severity and hospitalizations and the death down. So that's why I always tell my patients, you still might get it, but it should be less severe and keep you out of the hospital.
Could you clarify for me, when did you get the flu after the flu vaccine? How long after?
Probably, I got, at Christmas, I had the flu, the vaccine, I think I got back in September. The vaccine in September, and I think I came down with the flu in December.
In December, okay. All right, thank you. I just wasn't sure whether you were talking about an immediate, as George was mentioning. Often, if you're about to get the flu and you get the vaccine, it takes about 2 weeks to kick in for your immune to get a good response. So if you were in that window period, and you had the vaccine, but you're destined to get the flu, you're going to get the flu.
Well, we had also traveled out of our little bubble here,
Yes.
and perhaps that added to exposure.
In a good year, the flu vaccine is considered 60 or so % effective. It doesn't mean that 60% of people are just not going to get the flu. We're talking about really a large effectiveness rate to prevent, as Abby was saying, the complications associated with flu, the pneumonia that happens, the dehydration that happens, the hospitalization that happens, the death that happens. I had, so far this year, I just got this today, let me just pull up my email. So far this year, there have been 230, this is in the United States, let's see, 18 million flu illnesses, 230,000 hospitalizations, 9,300 deaths associated with flu so far this year, and 32 children died from flu this year. Okay? The flu vaccine mitigates that tremendously, and that's what we want. That's the purpose of getting the vaccine. You cannot get the flu from the flu vaccine. It is impossible. And I just wanted to clarify on that. Thank you.
Thank you, Barbara. Thank you.
Okay, we have a Zoom question. I don't understand why some people vaccinate their pets, but don't want to vaccinate their children. Can you help me understand this? Sounds more like a statement than a question, but does anybody want to take a shot at that in any way, shape, or form?
I agree.
I don't understand. I mean, you care more about your pet than your child? I hope not.
Yeah. That's
I don't know much about pets.
Other questions? Right.
Thank you. My name is Lisa Anderson. I live in Cornwall. And it had all my children immunized. I had twins and then another one 4 years later, and they all went through the schedule of getting immunizations. But I had conversations with the doctor about when and which ones, how fast do I have them. There was an urgency to piling on getting 8 when, you know, or could I spread them out a little bit? And I think that conversation is really helpful to parents, to the sense of the schedule. It gives them a little control, because I've heard this from some young parents. And I'm wondering if you could comment on that. How do you have a conversation with a parent who's willing to do immunizations but doesn't understand the schedule?
I can and you can.
Okay, do you want to talk at the same time?
Sure, let's do it.
All right, stereo. First of all, the immunizations are optimized for, get somebody...
Vaccinations, sorry.
I'm sorry?
Vaccinations, did I say? Oh, both of them. I said, yeah.
Vaccination.
Yes, she just vaccination.
She used a different word, immunization and vaccination, they're both the same.
Yeah.
Correct. I'm so sorry. Okay. Sorry. My next trip is to the audiologist. Yes, by vaccinations and immunizations, to me they're synonymous for our conversation. So the schedule is optimized for getting a proper immune response as soon as that's reasonably possible, and for getting somebody protected as soon as reasonably possible. For example, if you gave a 2-month-old a measles, mumps, rubella vaccine, it would not be effective. It would do very, very little, if anything. Their immune system is not, because of the way that the immune system responds to the MMR vaccine, it's not, a 2-month-old is really not able to mount a proper immune response. It would be wonderful to prevent measles in a 2-month-old, and we do that by immunizing around the child. So it was found actually in the 90s, we would, and prior, when the vaccine came out, I think in the 60s or so, children were initially immunized at 18 months of age. We knew that they would get a good immune response at that time, and that's why that time was taken. During the measles epidemic in the 80s and 90s, certainly I was this much into measles, and unfortunately in the intensive care unit taking care of babies with measles, with encephalitis and pneumonia and other things. So during that time, they started looking at some data, and they were able to move to see that the immune response can actually, there could be a reasonable immune response at the 12-month to 15-month time period. And that's the present recommendation for measles vaccine, is the 12-month to 15-month time period. However, during an epidemic, we do what we can to break that cycle. So we were actually immunizing 6-month-olds for measles, which we don't routinely do. But we knew they would mount some immune response, even though it would not last. But that's what helped break the epidemic, and the younger kids were the sickest kids who got measles. So at that point, we did something that we knew would not last, but that was the very brief epidemic schedule, and it actually still is. If you're going to travel internationally to an endemic area with measles or an active measles, we're going to recommend your child between 6 months and 12 months of age gets the vaccine, although we know that they're going to need to go onto the schedule and get 1 to 12 months. And then a booster at about 4 years of age in case the first one didn't work. Actually, one measles vaccine is usually enough after the age, after a good immune response, to cover you for life. A 4 year is done as a booster in case, for some outside reason, there was not a great immune response to a small number of people in the population. So that would be one example of an optimal time for an optimal immunity during a normal schedule. HIB, Haemophilus influenza type B, used to be, it probably is one of the most devastating types of meningitis, bacterial meningitis, that an infant can get. Okay? Unfortunately, I had to take care of children with this vaccine with this illness, excuse me, before the vaccine was available. And we're talking about children 2 months, 3 months, 4 months of age. HIB was also notorious for something called epiglottitis in toddlers, which is basically an obstruction of the airway due to the swelling from the bacteria. It is a medical emergency. So the first HIB vaccines were given at 18 months of age because that's when they worked. They didn't work on the 2-month-olds. It would have been great to put that in the schedule for a 2-month-old. It wouldn't have done anything. Okay? A few years later, they started working, they modified the vaccine, and now we were able to protect infants against the most deadly type of bacterial meningitis, incredibly common. Okay? I have a clip to show you. I don't know if this is helpful.
I'll bring it around.
You see, this is my my laptop. Okay. It's a clip showing what happened with HIB meningitis in infants once the vaccine came out. Within 2 years, it disappeared. It disappeared because of the vaccine. Being able to give it at 2 months of age.
And that's the clip.
Okay. So, and you can see very similar cliffs with the polio vaccine, the measles vaccine, rubella, mom said, they're all very, very similar. But this was considered, I mean, you talk about one of the deadliest forms of illness that you know, would devastate an infant, disappeared. So now we give that vaccine at 2 months of age. But because of the type of vaccine, that you need to boost and boost a little more as the body can handle it, as the immune response, becomes lasting. So it's given at 2, 4, 6 months. Then later on, they came some boosters in case, 12 months now after, in case there was a poor immune response for some reason during prior immunizations. So we could go, so the schedule in general is based on the science of, will the vaccine work? And will it last? And that pretty much, and will it protect that child as soon as possible? Okay? And I know that there is some debate right now, ACIP, CDC, created a mythology about hepatitis B. How could you possibly give that during the birth period? First of all, there are many people who opt not to. Nobody's required to do anything. But there's a very, very realistic reason to give Hep B in the birth period. Okay? If a baby gets Hep B, first of all, there's the mother-baby transfer of Hep B, but that's not always the case. It could be an exposure afterwards. Okay? Hepatitis B to an infant, they'll be symptomless for many years until they suddenly have chronic hepatitis. And we have them in the community. We have teenagers, young adults in the community, okay, with chronic hepatitis. We have adults who have died, you might know them, from cirrhosis and need a liver transplant, things like that, right? They had hepatitis B. They might have gotten it from, they were not drug users. They got it as babies. Right? So, again, a family that you know the history, you're not healthcare workers, you know you're going to be home quickly, the family makes an individual decision to change a schedule against the recommendations. It's understandable. Every physician wants to have a relationship with their family. And those are conversations to have with the family, with your physician. But the recommendations are based upon the data of effectiveness and usefulness as soon as possible. How is that for a short answer?
Anyone else on the panel want to address her particular question with any other aspect?
Well, I was just going to say that was a great question because I get that a lot in the clinic. And another thing I like to mention is whether you're getting 1 shot or 3 shots, that child usually, it's traumatic for the parent. They don't like to see them being held down, and I understand that completely. But the cortisol levels, they measure them, this has been studied, whether they get 1 shot or 3 shots, it's the same amount of stress they experience. And, my families will talk about being exposed to so many antigens at one time, and if you go to the library, you go to the playground, you're being exposed to way more than what we're giving in the appointment. So that always helps. So I thought that was a really good question. And I also tell people the schedule we have for kids is what's safe. Anything I do off of this is unsafe. And that's clear, it's not studied, I don't have the data. This is what I do know is safe, so I mentioned that too. But thank you. Did you have something you wanted
Any
to
follow-up on
add
that question?
that?
Any follow-up at all?
No, thanks.
Anyone else have any comments or questions based on her question and their answers there? Jessica?
Jessica Deuce, hi. Abby, I appreciated that you said that parents are concerned about the number of antigens that they're getting, meaning like the number of diseases at one time that children are being vaccinated against. I've heard that as a public health nurse quite a bit when I did WIC clinic, the maternal child health. And it is, you know, it's always like a conversation about, well, just living, you're exposed to so much. So it's nothing different.
Yeah, thank you. Yep.
So just a little follow-up to that. So in 1986, we immunized against 7 diseases. Today we immunize against somewhere between 16 and 18 diseases. We've increased the number of shots and decreased the number of antigens. 100 years ago, a smallpox vaccination gave about 200 antigens. The whole cell pertussis vaccine that we used when we first got the whooping cough vaccine had 2,000 or 3,000 antigens in it because we just ground up the whole bacteria and gave it to people. Now, if you look at the total number of antigens given to children under 5 for all their vaccines, the number is total is 165. So if you just look at what your immune system reacts to every day through contacts with people, through the food you eat, through touching your face and putting things in your mouth, you get exposed to thousands of antigens each day. So 165 is the number, so there's not a lot of antigenic exposure in the vaccination.
Okay, back row, Chloe, right behind you.
Hi, thank you for being here. My name is Rini. Just wonder if anybody can speak to on the panel about what we can see maybe in the next year with the people in the government kind of promoting a decrease in the measles vaccine. What is going to be the repercussion of that?
I think that first it should be said that that's a pretty concerning development, that it's a highly transmissible and highly morbid disease, can hurt a lot of people very quickly. I think my hope is that it will be a stress test to local public health infrastructure, and that states are going and municipalities are going to have to come up with their own approaches to addressing this. And it seems like Vermont, among other states, is moving pretty quickly to be able to deputize our public health officials to order vaccines from the federal government and administer them and get them covered by insurance. And so I think there is going to be a period of transition where a lot of the leadership is coming locally rather than nationally. And I am optimistic that there are a lot of public health warriors and champions who will make sure that we keep up with our vaccinations and highlight that these outbreaks are preventable. But I think it is a difficult situation we find ourselves in, and public health as a concept works at larger levels. And when the federal government's public health apparatus is healthy and working well, we all benefit from that. And I'm concerned.
Just real quickly to add, right now, 20 states have formally outright rejected the ACIP recommendation of decreasing, Vermont being one of them. Our health commissioner, our own...
Can you explain what you just said? I'm not sure that the...
Yes, I'm sorry. In terms of the new recommendations, because they are not based in science, and for many other, because they're politically based as opposed to scientifically based, formally, 20 states right now have rejected formally and officially the new 11 immunization schedule and are staying with the present schedule, which is scientifically validated. Vermont is one of them. We, right now in the legislature, H545, which just came out of committee yesterday, almost unanimously passed to allow for the Department of Health and our Health Commissioner, our own Rick Hildebrand from Rutland, to review and choose the proper adaptation of Vermont's immunization program. And right now, he is, of course, supporting the scientifically based one and is staying the same. So I think, the response of Vermonters is a resounding thank you, thank you, thank you. Meredith Plumpton, what would be your title? A public health nurse in charge of immunization?
Immunization program manager.
Thank you, Tricia. Immunization program manager. Presented to the Vermont Medical Society yesterday the response of Vermonters of appreciation for how the community is gathering, how the scientific, how the medical community is gathering to make sure that the immunization program stays intact. That includes insurance, which again, rejecting the CDC and ACIP federal recommendations may have insurance implications. I think I'm very hopeful right now that that will not be the case in this state. And we've got a very pro-vaccine state, thank goodness. We really, at least for as long as I've been here, that's the way it's been. So, and that seems to be continuing.
I just want to do a little bit of education about measles and why it's so dangerous. I mean, it's dangerous because it causes deaths and encephalitis and things. But in a room this size, if a person walked in here and had measles and coughed and left, and you walked in 2 hours later, and they coughed in that corner of the room, and you walked in 2 hours later and were in that corner of the room, you would likely get measles if you were unimmunized. Not might get measles, but likely to get measles. It's an incredibly infectious disease.
Anyone else in the panel for that question? Any follow-up? Any follow-up yours?
No, I think it's just concerning that.
Hold on a second.
When you think about some of the people that might be traveling from states that are not, the 20 states that are promoting for these guidelines, and you travel with your child who isn't immunized against measles, and you come to another state, and it's just very concerning.
Speak up. In the mic, speak in the line.
So it's just very concerning when you think about people that might be traveling with their child from a state that they're not immunized, and they come into our state. It's very concerning. But I'm thankful that 20 states are promoting this, and thankful that Vermont is.
And we knock that down by keeping our kids immunized, by keeping a high immunization rate. Then somebody with measles again. I was swimming in measles in my training, but I was immunized. I never got the immunization simply work. So we need to immunize our kids against measles. We will. You're 100% correct. There are outbreaks. What's happened in Vermont with measles so far in the last year or two? We get an isolated case, 1, 2, 3, possibly from travel, whatever, right? But it stopped dead in its tracks because we have a high immunization rate. We must keep that up.
Okay. Any other comments or questions based on this issue right now? What I'm trying to do is, instead of backtracking to something again, if you have a question about what's been brought up here, don't be afraid to toss your comments in and your questions. If not, we'll go on to another question. And since we have a Zoom, I'm going to ask the Zoom question here. It's funny, it's from the person who sent the earlier one. He says, "This is not my second question. It's from my wife, who is also on Zoom. What is the reason for the age cutoff for the RSV vaccine? I was not old enough to get it, and my husband was. I had RSV, was very sick, and ended up at urgent care. My husband had only mild symptoms of my disease. I've heard the age limit has now been raised from 70 to 75, just before I turned 70. Is there any way I can get the vaccine and not have to wait 5 more years?"
My understanding of the age cutoffs for vaccinations is the way the clinical trials are conducted. That in order to get approval for these vaccinations, you need to demonstrate that it was effective in a certain age population. And I think that there has been some gamesmanship around that when pharmaceutical companies want to get a new medication or vaccination approved, that they will pick sometimes cutoffs for their clinical trials around what they think will be most profitable or most advantageous. However, in adults, it is hard to imagine a biological plausibility argument about why vaccination of someone who is in their late 60s isn't the same as in their early 70s. And I think that it would be reasonable for someone at high risk at a younger age than the cutoff to receive those vaccinations. There may have to be some additional out-of-pocket payment, that there may be insurance implications for receiving the vaccination, but I think that in the face of a life-threatening illness, paying out of pocket for a vaccination may very well be worth the trade-offs. And my hope is that over time, some of these vaccinations, I guess the biological thought is probably that a person who is somewhat older is somewhat more likely to have a bad outcome from those illnesses. And so by studying a vaccine in 75-year-old individuals and older, you may be more easily demonstrate that there was a protective benefit against serious illness relative to testing it in individuals who are between 65 and 75. So I can see why it would make for a stronger case, but I also think that this is a great example of why vaccination is really a public health pursuit. That's something that we are talking about not on an individual basis, but on thousands, hundreds of thousands, millions of individuals basis. But when it comes to individual choices about vaccination and timing of vaccination, it's a one-on-one clinical discussion between you and your trusted advisor, your clinician, your PCP, members of your community. And I think that there can be some important discrepancies which we can all recognize have happened in our lives where the big picture guidelines didn't fit with what we thought was right for us or our families. And with good guidance, with a trusted advisor, you can make adjustments to the existing schedules that fit your life and fit your plans, even if they don't comport exactly with the recommended schedules.
And I'll just add to it. So I was just looking up too. Patients can self-attest to the presence of a risk factor. So 60 to 74, if you want the RSV vaccine. I know in my practice and my colleagues, we like to get people vaccinated for RSV. So definitely discuss, as Ben said, this with your provider because it's possible to get it. Unless you're like Superman, have nothing wrong, but.
Okay, well, this is for Mrs. Baird on Zoom. If you have a follow-up question, feel free to type it in for Greg. Anybody in the audience having any kind of follow-up questions or comments they want to make on this issue? I don't see anything on Zoom. If they do, I'll raise it later. Okay, next.
Hi, Jeff Malin. Less a medical question, more sort of an advocacy question. For those of us who are generally pro-vaccine, but have family members, loved ones who aren't or are more hesitant, do you have experience with avenues of conversation or ways of bringing it up with them that you have found productive? Because I have yet to find them, and I'm very curious about your experience.
You know, it was a big frustration in my practice, just that scenario. It was very difficult where we had family members who wanted to immunize their children. You know, they bring them in.
A little louder, David, if you would please.
Where I would have parents bring in their children and they would refuse vaccines because their vaccine refusing sister who lives across the country will disown them, let's say. You know, I mean, literally to that extent, the hyperbole that went on, where if somebody in the family was vaccinated, you know, I could never speak to my sister again if I ever do this. So they, based on that, refused to immunize their child. And I can't, you know, I guess it's tough when you don't think that way and you try to find common ground with somebody, but sometimes you just can't find common ground. Sometimes there's, you know, there's no matter, if somebody says, no matter what you say, I'm not changing my mind, it's very difficult to say anything, isn't it? And so it's a very frustrating situation. I do empathize with it, and it's actually painful. It was painful to me personally to lose family members, you know, from my practice because of it, you know. Some people do come around eventually, so it depends how militant those family members are, you know. I find that if you just keep shoving more and more data at refusers, it doesn't work. I think sometimes it's just patience and luck. Sometimes you just don't win.
I had success over time looking at why they didn't want to immunize, and then looking at what the background is behind that. What's the data? So, you know, there's a whole bunch of myths about vaccines that people use to say that they won't immunize. And I can go over those with you specifically, Jeff, if you'd like. And so that you have like a whole cadre of information that you can talk to your friend or relative about. So if you'd like that, I can point you in the direction of how to, you know, what the real data is and why these myths really are not, they don't hold water.
I think just to build on George's point, I think that asking open questions about why people have reluctance, I think that assessing what the core of their hesitancy is probably the most important first step. And I will say that a lot of discontent feelings in the United States and people who have contrarian views, a decent amount of it is because they don't feel heard. They feel disenfranchised and that the world or society or the government is not really listening to their concerns. And if you take the time to ask them detailed questions about what their concerns are non-judgmentally, people will both tell you their perspectives, why they don't want to get vaccines, but will often share with you reasons why they themselves are conflicted and why they may hold opposing views. And sometimes I'll use a specific approach which was developed for addiction medicine called motivational interviewing, where you ask patients these questions. Sometimes you ask them, you know, questions about why they enjoy doing a substance of use. And it sort of flips the conversation around from the traditional narrative and often has the individual engage in some kind of change talk where they show some ambivalence about their position before. And as a clinician, you know, don't have to be confrontational, that you can sort of roll with the resistance to allow the person to say what they need to say. And I often take a long view on it, that it is not about whether the person or their family member gets a vaccine today, but if in 12 or 24 months I've become a trusted advisor for them, and we can continue to have that conversation, I can get to the win in the end. And that sometimes you need to take that longer view.
Anyone else?
Oh, I was just going to give a shout out to a resource for you, Dr. Paul Offit. If anyone, I'm sure you guys have heard of him. If you haven't, he's like the leading vaccine expert. He has some videos and conversations about how to talk with family members about this. And he's brilliant at talking about it, so that might be helpful.
Any other questions pertaining to this topic or any more input or, okay.
Well, I have an observation relating to this topic, and it goes back just a few years to the pandemic, and just to cite two people I'm aware of. One I actually knew fairly well, and the other one was my stepson's father-in-law in Arizona. Both of them refused to get the COVID vaccine. One in Arizona died. One who refused to get it that I know very well almost died. Because the system, God only knows how much money, because he refused to get a vaccine. Now, and he was aware. I mean, we talked to him and said, why are you not getting it? Well, one of the things, he's a libertarian. He said, you can't make me get a shot. And well, he goes and he almost dies. So if these people won't listen to you and they're facing death and they see it all around you, then I'm not quite sure how you're going to get anybody to listen to you. But, good luck in trying, is all I can say.
I have found that there's a vast difference between vaccine hesitancy and militant vaccine refusal, that where there's nothing you can tell me otherwise. I believe them when they tell me that, if there's nothing I can tell them otherwise. But that's a vast minority. Examples of vaccine hesitancy, you ought to ask questions, be hesitant. How could you not with what's out there right now? Be hesitant, ask questions. You need some time, work with your family physician. But that's vastly different than, and we all know this, it might be political, whether it's vaccines, it could be about anything. There are some stubborn people who there's nothing you can tell me otherwise. Some of them may on their own, come around at some point. But I think if somebody tells you there's nothing I can tell you otherwise, I would disrespect them if I didn't believe them. So I believe them.
Any follow-ups from anybody here on that? Okay, then new questions, new topics. Barbara?
I do not have a lot of medical background, and so my question is, I hear about herd immunity. I think I understand that natural immunity is if you have an illness, your body recognizes that invader, and you will resist it the next time. Does herd immunity, is that what some people are promoting as a good way to, a more natural way to make our society disease-free? What is herd immunity?
So herd immunity is not, it's not something that you develop naturally, usually, unless you have an epidemic that affects nearly everybody in your population. Measles, herd immunity occurs with measles when 96% of the population is immunized. If you get below that, much below that, then you can have outbreaks of measles, which has occurred. South Carolina is the most prominent example where there's 80% immunization rate. But once you get down around 90%, it becomes more of a risk. And so herd immunity means there isn't enough people who are susceptible for the disease to go from one place to another. That the people who are susceptible are separate enough that they will not encounter each other if they get sick. So that means that, so if you think about 100 people and there's 4 of them that could get sick, and there's 30 or 40 people between those 4 in any way you draw the diagram, then you're going to have herd immunity. So herd immunity is something that doesn't develop from a natural state unless there's an epidemic. We don't develop herd immunity to influenza, even though it affects a lot of people and a lot of people get immunized, because the damn virus mutates every year and changes its code, so we don't get herd immunity. But measles, we can have herd immunity. We just need enough people vaccinated.
Can we move on? Herd immunity?
It does seem like herd immunity could use a rebrand. I feel like it is giving animal illness and not human illness. And I think what it opens this question about whether herd immunity is natural in terms of like wild type vaccine or immunization based. And I think that George's point that herd immunity only occurs for vaccinations and illnesses where we have vaccinations is the important point.
Okay, other questions, comments?
I do need to make the point, since you moved at us. The smallpox vaccine was originally developed from the cowpox vaccine. And one of the concerning side effects of the anti-vaxxers at the time were the claims that they would be turning into cows. This is true. I don't think more than 1 or 2 people actually did turn into cows, but you made me think of that. Okay.
I had a cousin named Holstein, but... Okay, any other questions or comments, follow-ups? Are we looking for a closing statement from the board of some sort? Don't all jump up at once. Oh, I'm sorry, Chloe, our wonderful mic presenter.
This might be backtracking just a little bit, but I was wondering if you had anything to say about the myths surrounding vaccines, that they cause neurological disorders like autism. Because I've heard that a lot. Is there some reasons that is why people don't want to get vaccines?
Yeah, thanks for your question.
I'm sorry, we don't want to answer this one.
Yesterday's report that autism is caused by the wildfires out west, did anybody else see that? The smoke inhalation of the parents, it's on NBC News report, okay? Smoke inhalation from prenatal, from pregnant moms is responsible for a higher risk of autism, right? So is Tylenol, by the way, right? Oh, wait, maybe not. The latest study, it's not. Okay.
So
immunization study causes autism. That's right. The long answer.
Right.
Study millions and millions and millions and millions and millions and millions. Doesn't happen. Doesn't happen. What happens with families with children with autism that I have seen, and it's actually quite sad, where their first child might have autism, so they'll refuse immunization for the second child, and the second child has a very high risk of developing autism. And you all might have community members where you might know that. It's not so uncommon to see that. The immunization, the autism rate in immunized children, in immunized adults, and immunized people with autism, it's the same immunized or not, same rate of autism. Okay? It's because it's the wildfires out west. Or not.
Anybody else on board for that?
I was just going to, I was just going to say that the study, the hypothesis, it was a paper written by this GI specialist in Germany, right? And his name is Andrew Wakefield, and he, that's kind of where it started, if you were asking about that. So I think that's kind of where it went. I don't know if you want to talk about that, but
No, I just think that the best conducted science, that this is a question that has been asked for a while and has been conclusively answered for a while, and there has not been any convincing data on the opposing side, that it is really there are few questions in science that are as clearly decided as the inability of vaccinations to cause autism.
It just doesn't happen.
I brought along a great article. This is, it's a big talking article that's around right now. This is a study looking specifically, the cause of the day is aluminum, the micrograms of aluminum that act as an immune stimulant in a few vaccines. There was a Danish study done over, from 1997 to 2020, so what's that, 23 years, looking at children over 22 years, 1,224,176 children born in Denmark between 1997 and 2018, and they looked at autoimmune disease, they looked at autism, they looked at, you name it, baldness, and they found zero. It just wasn't there, it's just not there. And so that was just published in October this year in Annals of Internal Medicine, and you will be hearing back and forth. RFK wanted us to just reject and ignore this gold standard article. It's becoming a gold standard, peer-reviewed, looking at it again. And this is on top of a number of recent European and particular studies that have shown very, very similar effects. That there's just no association. It's just not there. It's just not there. Great to ask questions.
Right.
Great to ask questions, but listen to the answers, especially when they have been reviewed and peer-reviewed and replicated again and again and again and again and again. No autism.
So the other,
I was just gonna say that I find it quite concerning that people still believe this even after all the scientific proof that's been given surrounding it.
Yeah.
So-
I was just gonna say, I think it's easier to scare people and really hard to unscare people. So even this one person could evoke this much fear, and that's kind of why we're here.
so in Germany, they studied 17,000 children to look for allergies, asthma, ADHD, epilepsy, and they looked at these kids over years. The only difference they found between the vaccinated and unvaccinated children was that in the unvaccinated children, there were more incidences of vaccine-preventable diseases.
Okay. I want to thank the group that organized, excuse me, one last question over here.
That last part. Now that we get to talk about autism, my son recently got diagnosed, and now you kind of got me worked up about it because this has been very difficult for me. And when he said that, the terrible things he said about people on the spectrum, and it was terrible, and it has more to do, nothing to do with vaccines. It's the age of the father. The older the father is, they find a lot of connections with autism on that. It's a neurological thing. It has nothing to do with just when people talk about autism and vaccines and stuff like that. It just kind of sends me over the edge, and I don't. That wasn't really a question. So that was just kind of on a soapbox.
It was a really
That they don't have anything to do with it, and it just infuriates me.
Thank you. You're making such an important point of maltreatment of human beings, is what you're talking about, from ignorant people. All right.
You're able to have completely fulfilling lives, and I support my family and have a job, and I play baseball, and I did all that stuff that they're not supposed to be able to do, and of course, it kills me.
Yeah, I guess, in terms of I'm just thinking, I'm visualizing a dear friend, whose son graduated Cornell, is entrepreneurial and is neurodivergent. I guess that's one of the terms that are used. People are people, and there are a lot of different ways of thinking. Everybody thinks differently. Brains are structured in many different ways. And, at some point, people will see the light and understand just what you're talking about. It takes time, because there's so much ignorance out there. Thank you for sharing that.
Yeah, I won't continue, but I think, I heard somebody say, one of the best ways to kind of describe people on the spectrum was, they said, the biggest difference with people on the spectrum is we've just found something more interesting than socializing with other people.
You're here. Okay, I want to, again, thank the organizers that put this together. Anytime you can get information out there, get both sides of stories, and both types of comments is important. Abby, Ben, David, and George, thank you very much for your evening. And I pushed the cold, stormy weather to tomorrow night just as it'd be better today. That's a Chamber of Commerce skill that I do have. Be careful on the sidewalk, be careful on the steps, be careful in the parking spaces, and have a good night.